Welcome back to our Department of Medicine Academic Feast. Today we have with us Dr. C. Epan. Sir is the professor in the Department of Hepatology, Christian Medical College, Vellore. We have for today the topic New Therapeutic Avenues in Liver Failure Syndromes. Sir will cover this topic over the next half an hour to 1 hour. Sir's current research interest is in disorders of microcirculation in the liver and plasma exchange to treat severe liver injury. As you all know, Sir is the ex-members of our CMC Vellore Hospital, and he is very well known to everyone and a very approachable and a very knowledge teacher. I hope any questions, if you have, please feel free to ask Sir directly, or you can put down in the chat box. And we are really grateful to have you, Sir, here with us for this lecture taken for us. And we'll be uploading this lecture soon on our Department of Medicine YouTube website. So thanks to you again, Sir, and over to you, Sir.
Thank you, Anju, and thank you to Department of Medicine for this invitation. I'll get on to my topic of discussion, that is on newer therapeutic avenues in liver failure syndromes. So I would like to cover just these three aspects, and I hope it could invoke some thinking process in the different people who are listening. So first is the question, in toxic hepatitis, what is the equivalent of paracetamol overdose in Tamil Nadu? That's the first topic I would like to discuss. Now, I would like to draw your attention to a recently completed study by the Tamil Nadu chapter of the Indian Society of Gastroenterology. This manuscript has been accepted for publication and should come out very soon in the Indian Journal of Gastroenterology. So the aim of the study was to assess exposure to rodenticide as a risk factor for acute hepatotoxicity in Tamil Nadu. This was a retrospective study conducted in the first 6 months of 2019. The inclusion criteria were patients with acute hepatotoxicity due to ingestion of a hepatotoxin or any potentially hepatotoxic drug overdose. We excluded patients who had idiosyncratic DILI, that is drug-induced liver injury, or patients with chronic liver disease. Now, there are 37 districts of Tamil Nadu currently, and in this study, 15 hospitals, both government and private, from 6 districts of Tamil Nadu participated. Now, in the 6-month time period, there were 702 patients who attended these 15 hospitals with the diagnosis of what turned out to be toxic hepatitis or ingestion of this hepatotoxin. 685 patients had a history of having consumed rodenticide or rat killer, while 10 patients had taken paracetamol overdose. So if you were to convert that into a ratio, the proportion of patients who had taken a rat killer overdose and a rat killer poisoning ingestion versus paracetamol overdose. And this slide refers to those who developed an altered LFT. So they had hepatotoxicity was 450:6, which works out to 75:1. So for every one patient with the paracetamol overdose causing hepatotoxicity, the rodenticide causing hepatotoxicity was 75. Now, of the 450 patients with rat killer poisoning causing hepatotoxicity, majority were young, and this was the syndromic classification. As you know, both the different societies of liver diseases, like the American and European societies, categorize acute liver dysfunction into either acute liver injury, where a person has got, along with deranged LFT, a prolonged INR, coagulopathy, but no encephalopathy, while acute liver failure or ALF refers to the presence of encephalopathy in addition to coagulopathy and deranged LFT. So in this study of 450 patients, 54% had ALF, 17% had ALI, acute liver injury, only coagulopathy without encephalopathy, and 19% had neither coagulopathy or encephalopathy. 35% of these patients died, and as I mentioned earlier, majority were very young. So this study has documented for the first time when you do it on a statewide basis in India, that rodenticide, that is yellow phosphorus injection, is the equivalent of paracetamol overdose in Tamil Nadu. All our textbooks mostly are written by Western authors, and in those countries, paracetamol overdose causing hepatotoxicity is the big problem. Our equivalent in South and Western India mostly is rat killer or rodenticide injection causing hepatotoxicity. I'll move on now to the next topic, which needs some thought, and I hope will translate into more lives being saved in our state. This is a problem with the use of sedatives in patients with severe liver injury. So this is a common situation, at least in liver clinic, a common referral. A patient with pulmonary tuberculosis has been started on anti-TB drugs, INH and rifampicin. At start, the LFT is normal. 2 weeks later, there is DILI, drug-induced liver injury. The bilirubin has gone up, SGPT is high, INR is prolonged. So everyone knows we should stop these drugs which are potentially hepatotoxic, and in this patient, looks like it is hepatotoxic. Our concern is if you continue this medicine, the hepatotoxicity may worsen. Let us assume this patient needed to undergo bronchoscopy. And as you know, bronchoscopy is an uncomfortable procedure. So we would give sedation as a pre-medication. We give midazolam. So if this patient needed bronchoscopy and a pre-medication with midazolam, when the LFT was normal, there is no issue. But let us say we are at the 2 week later situation. For some reason, a bronchoscopy is needed. So then it's not so, one does not go so easily in the decision. We may wonder, because we have a concern about midazolam here, is bronchoscopy really needed? Should we do an invasive test like this in a patient who has already got some sort of liver, in fact, is categorized as acute liver injury? Or maybe should we use a smaller dose of midazolam? So thereby the concern is whether the sedative midazolam here in this patient with acute liver injury could trigger respiratory depression. Now, when you think it through, midazolam is not hepatotoxic, is not toxic to hepatocyte, in contrast to INH rifampicin. However, almost all sedatives like midazolam are metabolized by hepatocytes. That means they are made more water soluble, and then it is excreted in the urine. So in a setting of hepatocyte dysfunction, midazolam is not getting excreted in the urine because it's not so water soluble, and thereby it accumulates in the bloodstream. This in turn may reduce my level of consciousness and may make me prone for respiratory depression. Now, I was looking around for a study in literature which would support this point of view. And I found today morning this article in Japanese, but I read the English version. The abstract says that the authors studied the pharmacokinetics of midazolam in patients who underwent either hepatectomy for evident liver disease, liver tumor, versus gastrectomy, there was no liver disease. And the anesthesia was induced using midazolam. And after that, they did serial monitoring of midazolam levels for 8 hours. They could show that the half-life of midazolam was 24 hours in the hepatectomy patients compared to 8 hours in those who had gastrectomy. These patients did not have a liver problem. So it appeared from this data set that in hepatectomy patients with liver damage, the elimination of midazolam is prolonged, but whatever other parameter they looked at had no difference. For example, recovery time from anesthesia was the same in both the groups. Now let us replace that clinical scenario of the patient with pulmonary TB as a patient with rat killer poisoning. So this patient has come to casualty now. On day 1, LFT is normal. Now often this point of view, at this point in time, the discussion does not necessarily involve more than one doctor or not necessarily a senior doctor. Neither a referral to another unit is practical or required, I think. In contrast to the ATT, where in liver clinic we will be getting referrals. So when the LFT is normal, it should be fine to give midazolam if we wanted to give it for placement of an NG tube. Now, there's no need to give a sedative here. I'm just using an example. But let us say this patient consumed this poison for in your family conflict. The person is already in distress. The family members are in distress. To put an NG tube, it may be easier to have the person calm down a bit, maybe. Let us say this patient came after 3 days. That is by when, if there is hepatotoxicity that starts to happen. On day 1, it doesn't happen. So then the situation dramatically changes, and it's possible that this act of giving midazolam may now trigger respiratory depression. In some patients, this may lead to intubation, and then the whole sequence may have a very different outcome to survival. So I think in both the situations, I would, now that I am more aware of this topic, I wonder whether I should avoid the use of sedatives like midazolam. Now, we all know that in acute liver failure, what kills the patient is raised intracranial pressure. There is cerebral edema, and this, when it is uncontrolled, the person dies of uncontrolled cerebral edema. So thereby the treatment is aimed at dehydrating or using osmotherapy like intravenous mannitol or hypertonic saline as infusions. In addition, in a restless patient, it is recommended to give sedation to prevent surges of rise in intracranial pressure, which can lead to death. And thereby the aim is to keep the patient stable till an opportunity for emergency liver transplantation. But the ground reality in most of India is very different. I'll come back to this Tamil Nadu IAC study. In that study, the authors could extrapolate using this data set from the 6 districts of Tamil Nadu across Tamil Nadu state. And in those 6 months of 2019, just 2 years ago, we could extrapolate that maybe 1,500 patients would have come with rat killer poisoning with hepatotoxicity, and 554 would have died. In that entire year, in Tamil Nadu, this is data from the Tamil Nadu Transplantation Authority, Government of Tamil Nadu, TransTan, 3 patients underwent supraurgent cadaveric liver transplantations. I would guess a few more would have undergone live transplantations, urgent live transplantation. You can see the vast difference between the need and the reality. So, urgent liver transplantation, that means transplant within the next 1 to 2 days' time, is not the reality for most patients with acute liver failure in Tamil Nadu at present. Now, most of the guidelines on the management of acute liver failure are from the West, where urgent liver transplantation is possible in a high proportion of patients. So thereby, in the guidelines, though not much attention is paid to it, there is some sections on when to sedate, when urgent liver transplantation is possible and not possible. But suppose we live in another country, let's say we are in India, where urgent liver transplant is not possible for the vast majority. In the Tamil Nadu IAC study, that is not possible in 99.8% of patients. Then the question comes, why sedate at all? And this could literally be life or death in these patients. We have tried to discuss this difficult topic, having different specialists contributing to this article, and I would encourage those who are interested to look up this article, which is free of cost. Just the article has come out, journal has been started this year by the Tamil Nadu Society of Gastroenterology, where, for example, during intubation, one could use sedatives, but in all of the situations, it's probably best avoided in the settings of resource constraint, where there is no possibility of urgent liver transplantation on the ground. Now, this is in a way very similar to the recommendations for a patient with snake bite with neurotoxicity. Here again, one of the big concerns is respiratory depression, and it's contraindicated to give sedatives. So I just used the last few minutes to highlight the concerns about use of sedatives. I am of the opinion that some patients in some situations do need the use of sedatives in this scenario. However, one should not use it freely, and one should be cautious about when we use it. And if you use it, we should use in the smallest possible dose for the smallest duration of time. Let me now move on to the last topic, which is plasma exchange. This is now more and more fashionable in CMC, and not only in CMC, more and more being done in different centers in India and all over the world for liver failure syndromes. And this seems to be saving lives. Plasma exchange is a very old treatment for diseases of different other organs. For example, in Guillain-Barré syndrome in neurology, or in TTP in hematology, it's going on for many decades. But in liver failure syndromes, this is a new entrant, an old treatment for a new indication. We are increasingly using plasma exchange. We call it PLEX, to treat patients with acute liver failure or acute on chronic liver failure. So the American Society for Apheresis has periodically brings out guidelines, and this is the 2019 guidelines, where they have graded the evidence for the use of plasma exchange in 650 odd diseases of the body. That means not only for liver, for all organs of the body. And they, using the evidence currently available, they try to recommend, is it good treatment or not? So 2 years ago, based on the, primarily based on one well-conducted RCT, high volume plasma exchange is now recommended as a first-line therapy, either alone or along with other treatments for treatment with acute liver failure. While standard volume plasma exchange, they've decided the evidence is not so strong and could be decided on a case-by-case basis. I just would like to contrast that in patients with acute liver failure, liver transplantation has never had a randomized controlled trial. It is considered the standard of care, but this is based on cohort or case control studies. So it is recommended strongly, but the evidence base is not based on randomized controlled trials. Now, this graph gives the idea of the number of patients undergoing plasma exchange in CMC, in hepatology. Many years ago, 20 years ago, we used this treatment called albumin dialysis or MARS in 6 patients with liver failure, but we never bought the machine. That means we were not encouraged by the survival benefit. Patients seemed to improve transiently, but they did not survive. This is the experience world over with MARS. On the other hand, once we started doing plasma exchange, we can't seem to stop. Even during the COVID pandemic, even this week, there is a patient, even today, there's a patient undergoing plasma exchange in our ward. So I think increasingly, we seem to be encouraged by the survival benefit, though we haven't done a randomized control trial, but that's become increasingly a treatment that we use. Now, what is plasma exchange? It has got 2 components. One is removing plasma from the patient who's got some acute illness, in our case, acute liver syndromes, liver failure syndromes. So the plasma is in a state of disease, and it's replaced by fresh frozen plasma is preferred as a replacement fluid in liver failure from the healthy donor in blood bank, where the plasma is in individual in a state of health. Now, a combination of plasmapheresis plus replacing with a fluid is termed plasma exchange. In an adult, we all have 5 liters of blood in the body. Half of that is plasma. So 2.5 liters is plasma. So there are different types of plasma exchange used in liver failure. The high volume plasma exchange, a randomized control trial from Europe, used 4 times the plasma volume. That means they used about 10 liters of plasma was exchanged per day for 3 days. They almost wiped out their blood bank. This study from ILBS Delhi has used standard volume plasma exchange, in which they used 1.5 to 2 times the plasma volume. At CMC, we have been using low volume plasma exchange, 0.5 times the plasma volume. Suppose 2.5 liters is my plasma volume, about between 1.2 to 1.5 liters per day. Now, this is the volume used, for example, in Guillain-Barré syndrome in neurology, and we have been following that. And there are these publications which have been detailing our experience in this area. This is preliminary analysis. Now it's been sent for publication of one example of where we have compared patients who underwent standard medical therapy with severe alcoholic hepatitis, where to date, the survival benefit by using steroids was a 30-day survival benefit. Slowly, we are starting to see survival benefit up to 90 days by using this therapy. And we think as we are gaining more experience and improving our protocol, this survival is increasing even further. I'll now move on to some thoughts, some points of research we've been working on to try and figure out how is this benefiting these patients with liver failure. So these are some of the mechanisms I would like to cover. One is about the VWF platelet interaction. We started with, from this angle, the question, how come PLEX plasma exchange or the plasmapheresis component of it is improving survival? Now there are studies from different parts of the world in acute liver failure and ACLF. But till now, any other form of renal replacement therapy did not do that. So any form of dialysis had not so far been tried world over, did not improve survival in acute liver failure or ACLF. So we think one way to, so maybe if there are molecules in the substances in the plasma, they are not the cells in the fluid component, which are bigger than that can be dialyzed. For example, in dialysis, molecules up to 60 kilodaltons can be removed. So those which are bigger than 60 kilodaltons, then maybe such molecules, and there must be many of them, could be one explanation how PLEX helps in patients with acute liver failure. One such candidate molecule is von Willebrand factor, or VWF. VWF is very familiar to medical students. This is a blood clotting protein, and deficiency of VWF leads to von Willebrand disease, which is the commonest blood clotting disorder which is inherited. Our scenario is the opposite. The VW levels are raised in these syndromes of acute inflammation, in acute liver failure and ACLF. And as you can see, the VW multimers circulate in the bloodstream in different sizes of dimers, multimers, and ultra large molecular weight size. These are very large in size, and these cannot be dialyzed. So it's possible VWF is one such factor which may explain what is getting removed in the plasma. In fact, this paper states that VWF is the largest known plasma protein in health. There are various studies now which have come out in the last few years, of which these two studies are from our department in CMC. The first two studies are in cirrhosis, and this data has now entered the textbooks of gastroenterology, where in the outpatient cirrhotic, the plasma VWF antigen levels is equal to MELD score in predicting survival over 24 to 30 or 2 to 2.5 years time, and they are 2 to 3-fold elevated. In contrast, we have shown that in patients with ACLF, as well as in patients with rodenticide-induced acute liver failure, liver injury, the VW level are much more elevated, are 4 to 7-fold elevated, and they are equal to or better than MELD score in predicting survival, and it predicts survival for the inpatient stay over 7 to 8 days time. This data has now been replicated from a study across USA, where ALF due to various etiologies also has been shown to be predictive. The VW levels are elevated and predict survival over 21 days time. So it appears that VWF could be one candidate molecule which is getting removed in the plasma exchange process and how the benefit happens. VWF is produced in the endothelial cell of the body and is stored inside this organelle called the Weibel-Palade body. So this organelle would sit, say, for example, next to the let's say that's next to nucleus and mitochondria, etc. And inside the Weibel-Palade body, the VWF protein is kept stored as tubules. It's almost like a garden hosepipe. Now, if in an acute inflammatory scenario, this endothelial cell is activated by the inflammatory milieu, then this cell would start expressing these finger-shaped tubules which start coming out of the cell, and they are quite sticky. So let me use this example of dengue infection to explain what's happening. So why do patients with dengue develop acute thrombocytopenia? We know this is a big problem. In the dengue season, both in the adult and pediatric casualty in CMC, there will be throngs of patients or parents of children in pediatric casualty waiting to find out the platelet count twice a day. It's a moment of great anxiety. So let me try to explain this using this movie, Finding Nemo. So if you haven't watched it, you have to watch it. Otherwise, you can't understand this story. So this movie ends outside the Sydney Harbour. You can make out the opera house there. This ocean is full of fish. So if you take a sample of seawater, when you take a sample of blood from the patient, there are more cells per cubic millimeter than there are fish in the sea. Of course, it is just an analogy. If you use a microscope, there will be more organisms in the ocean water. And in the blood cells are thousands to millions per cubic millimeter. It's mind-boggling, really. Now, in this movie, when a scary chap comes, the shark comes, all these fish go and hide somewhere. That could be what's happening in this acute inflammatory syndrome of dengue. And now when the junior doctor takes a blood sample, suddenly the platelet counts have gone down. But the platelets are all still in the system, but they are hiding, they are sequestered onto the endothelium. A few days later, this shark moves on. Inflammatory scenario goes out. These platelets start coming out into circulation again. Now, in the same movie, there are these corals in the Australian Sea, I think, the Great Barrier Reef. This is how VWF molecules would look. They come out as finger-shaped projections out of the endothelial cell, and they're very sticky. And onto this sticky finger-shaped projections, the platelets stick. So this interaction of VWF with platelets is now described in a variety of acute inflammatory syndromes in all organ systems of the body. It's not only for liver. So this is applicable and there's a lot of literature now on this. So in these acute inflammatory syndromes, there is increase in VWF levels. There is a decrease in the enzyme which cuts VWF, that's called ADAMTS13. So this imbalance in the ratio predisposes to the formation of platelet microthrombi. So it's common practice that we do rounds, we find suddenly unexpected platelet count of 8,000. So with the junior doctors told, please ring up the clinical transfusion medicine department and ask them to have a look at the slide again. And they say, now it is 20,000. So when they check that, they say, hey, this actually was a clump of platelets, which the Coulter machine counted as a single lymphocyte cell. So this phenomenon, probably these platelets are getting stuck to bits of VWF floating around the system, is something which we do on rounds every day in these acute inflammatory syndromes. So in this cartoon, that's the, let us say this is an arteriole going on to a vital organ, say it's liver or lung or kidney. And that's the ultra large VWF molecules getting expressed in a situation of acute inflammation. The ADAMTS13 shown as scissors in these cartoons, which cut the VWF molecules, are lesser in the levels come down in acute inflammation. And this imbalance predisposes to formation of platelet and other blood cells getting involved in the microthrombi here. Let's say this is a patient with dengue with an 8,000 platelet count. If we now transfuse platelet concentrate to this patient, it's possible that we will predispose to more formation of platelet microthrombi. On tomorrow on ward round, we will say, it looks like this patient is getting acute kidney injury or acute or ARDS or some other organ failure, the functional organ failure recognized by the clinician. In fact, this point was contrary to what is practiced in CMC as well as in different parts of India. So Sukesh Nair and I had felt moved enough to write a small piece on this in IJMR, highlighting the potential dangers of isolated platelet transfusion in patients with dengue, suggesting, if possible, avoid platelets. But if you have to give platelets, first give the enzyme which cuts BWF, that is ADAMTS13, in FFPs and then transfuse platelets. This is a protocol we have been following now in hepatology for the last, I think, 7-8 years for any reason to transfuse platelets in patients with liver disease. I'll move on now to this point about the traffic jam in liver sinusoids. So let me use the example of this picture of CMC Hospital town campus from top. As you know, there are many departments in CMC, and I've highlighted some of the departments where there's a talk given to gastro and liver alumni. So that's why there's a preference shown to some of the gastro buildings and liver buildings. So we know that there is 2 entrances here. And if the patient, if it's a non-COVID time, this hospital can handle, let's say, 8,000 to 9,000 outpatients per day, can do it. This, as you can make out, this whole hospital is the liver. Now, if this entrance is starting to get blocked, then the liver would fail. If the entrance starts getting opened again this hospital can see more patients. So we are all familiar with this, that if you come into the hospital by 8 o'clock or 9 o'clock in the morning, again in a non-COVID, non-lockdown time, it can sometimes be very frustrating to get into the hospital. And in fact, it can be life or death for some patients with an acute emergency. This whole, this road here is, we call it the sinusoid of the liver. This whole microcirculation is jam-packed with a variety of cells which are either flowing in or they are actually resident on the sides of the cell. These yellow autorickshaws are the macrophages. We call them Kupffer cells in the liver. Or you can make out this bullock cart or ox cart, which are the large proteins, example of BWF. So let me now move on to this phenomenon of innate immune response. Now, the patients that we have picked out for Plex seem to have an overactive innate immune response. The immune system of the body can be divided into innate and adaptive. When the enemy is a microbe is recognized by the body, the generation time of most bacteria is 20 to 30 minutes. So the innate immune response has to rapidly act, in contrast to the adaptive B or T cell response, which may be days to weeks to kickstart. So there are many departments of the innate immune system. One such department are the cells, which are soldiers there, and to act very rapidly, one of the strategies used is to actually eat the enemy. So these cells are called phagocytes, and you can make out the macrophage. The asterisk, I think, is a neutrophil. So this guy, rather than eat the cell, may actually spray some juices or cytokines and then eat the cell. So this is a picture of actually a neutrophil literally eating an anthrax bacillus. Sometimes this phenomenon can become uncontrolled. So uncontrolled activation of macrophages, wherein this guy keeps on eating, this guy keeps on spraying cytokines and eating, is termed macrophage activation syndrome. This can be triggered by microbes, dead or damaged cells, or foreign materials, drugs, xenobiotics, leading to much more increased inflammation, tissue destruction, organ failure, and can be life-threatening. Now we have markers and criteria to diagnose macrophage activation syndrome. And in this particular study, we had looked at patients with severe alcoholic hepatitis. There were 50 such patients, and they were all very sick. And we looked for markers of macrophage activation, which is raised ferritin more than 500, or CD163 and CD25. And we could show that these reticuloendothelial activation markers, I could explain that, how that is another terminology of this part of the immune system. Activation correlates with severity of liver disease and predicts death in patients with severe alcoholic hepatitis. The endothelial marker also was studied in this particular study, and we could show that raised VW levels correlated with disease severity and with death. So, simplistically, we think what's happening in acute liver failure or ACLF is one is trying to bring back the traffic flow in front of the hospital by 3 in the afternoon, where we can zip through. And if patients were to come in, the hospital can do the job very easily. We just have to unclog the clogged microcirculation. So here is an example of, now we have crossed 230 odd patients who have been treated with these different acute liver failure syndromes or ACLF syndromes in our department. Here is a 14-year-old boy. The diagnosis was hepatitis A plus possibly drug antibiotic-induced acute liver failure. He was quite sick. He also had acute pancreatitis, acute kidney injury, some amount of fluid overload as well. Now, that is his bilirubin when he came. There is amylase. Ferritin more than 500 is macrophage activation. And VWF more than 150. So it's not markedly elevated here, but still he has got endothelial activation. He also had raised creatinine. He underwent plasma exchange twice here. He rapidly improved. I've got to see him 3 months later, and later on I've discharged him for follow-up. He remains well. I've told him there's no need to come back. Here that another child, teenager, who after taking a herbal drug developed acute liver failure, was in early encephalopathy. At arrival to medical ICU, the VW level is now 700. Underwent 2 sessions of plasma exchange. She became very well. Now, to normalize, the VW level 100 is normal, 50 to 150 is normal. Took about 3 weeks or 3 months. The platelet counts was 1.6 lakhs at admission, had dropped to 40,000, improved to normalize, took 3 weeks or so. So as you can see, what's happening in dengue over 3 to 5 days is happening over weeks to months in patients with this drug in idiosyncratic DILI in this patient. We put out a variety of publications in this area, and who are interested, I would encourage you to look this up. So I'm now coming to the close of my talk. Which are the patients that we have been selecting for treatment with Plex and low-dose steroids? The exact protocol, etc., is given in these articles if you look through it. So we are picking patients who have organ failure. That means they should have either acute liver failure or acute and chronic liver failure or severe acute liver injury. Some patients with severe acute hepatitis, they are not in liver failure. In addition, they have evidence of reticuloendothelial activation. The endothelial activation shown by raised VWF is something which we have in CMC. Sukesh Nair has done a phenomenal job of setting it up. It is the cheapest in the world with a rapid turnaround time of 4 hours. The result comes. I think nowhere else in the world is available like that. Raised ferritin is available everywhere in many places, and a level of more than 500 alerts you to a patient where possibly one could use this treatment. Now, this is an electron microscopy picture again of the liver sinusoid. This is the endothelial cell, the sinusoid endothelial cell, which is fenestrated. And this is this net-like appearance is the macrophages. this appearance is called reticulated. That is why the macrophages are called reticuloendothelial system. So we're looking at reticuloendothelial activation. Now, if a virus came to me and my innate immune response immediately kickstarts, I shouldn't know it. And I slept through it, let's say, and I didn't realize it. But if the system gets over and I have no symptoms, on the other hand, if the system starts getting overactivated, then I could start going into macrophage activation syndrome. Interestingly, one of the criteria to diagnose MAS syndrome is fever. So it appears that the fever in a viral infection could also be partly, we can view it from this angle as well. However, if there is an organ failure, there appears to be overactivation of the system. There are no good definitions for this. I'm just bringing in a concept. And such is the patients where we think the benefit of plasma exchange is happening in this new exciting treatment, which we are now able to offer and save lives in patients with acute liver failure and ACLF. I'd like to acknowledge my mentor, Professor Elvin Elias, who is emeritus professor at Birmingham in UK, who is also an adjunct faculty in our department here, as well as Dr. Ian Mackey from UCL London, who also helped us set up these VWF assays in CMC, and a variety of other departments which have been involved in the care of these very sick patients. And to avoid plagiarism, I am also acknowledging Asterix and Walt Disney. Thank you.
Thank you, sir. I think that was one of the best and most interesting lectures that I think we would have had. I think it just did exactly arouse the interest in everyone. I think the pictorial representation was quite good enough and very effective in conveying the message. I hope so. Any questions, please put down the chat box. So that was like the maximum we could have ever had an explanation on how we would have wanted to decide on how to give a patient on a flex therapy. So just there's a question already there. One question is in rodenticide poisoning can raise plasma 1 milligram factor level predict poor prognosis, and is it reasonable to consider raised WWF analysis criteria flex in rodenticide poisoning? That's what one I also want to ask. Does it help in prognosticating also and also in diagnosing and differentiating between diseases also?
The answer is a resounding yes. Okay. Now, again, as I said, in this area, some of the work is from CMC only, and we published this. So specifically in rodenticide poisoning, this was a thesis topic of one of our DM gastroenterology students, Debasis Sardar, and we could show in that paper that of 24 patients with rodenticide poisoning, VW levels predicted was 4 to 4.5 fold elevated. It predicted death at time of discharge from W ward from our hospital. That means over 8 to 9 days time. And the area under the curve as a predictor of survival was better than MEL score. So that's what we found. Subsequently, as I mentioned, a Pan-American US study has come from the US ALF group, and they looked at multiple causes of acute liver failure, and they could again show raised VW levels predicting survival over 21 days. We showed it over 9 days time. But we had one specific etiology, and that's the strength of what we could do. Now, should we have criteria for plex in rodenticide? So I think the reality is right now, VWF test is available only in few centers in the whole world. And surely there's no place like what Sukesh Nair set up in CMC where you can get it within 4 hours at such a cheap, low cost rate. So it's really not practical to use VWF in outside of CMC. So that's why I like the concept of ferritin. You know that even in COVID, ferritin, which is an indicator of macrophage activation, more than 500, alerts you to something more where you want to focus on in this innate immune activation. So that is what I tried to cover in the last few slides. How do we select our patients? The first is there should be a clinical syndrome. The clinical syndrome should be either acute liver failure or severe acute liver injury or ACLF. And in addition, if the VWF is high and ferritin is more than 500, it helps me to, I'm more confident that I will be doing some good because these macromolecules are not getting removed out of the body so easily, and they're clogging up the microcirculation in the liver. And literally, it's a traffic jam. It's a 8 to 9 a.m. phenomenon in front of CMC hospital, and we're trying to improve that. Interestingly, it looks like if somebody has got von Willebrand disease, then I should be protected against getting severe acute liver failure syndromes. If this hypothesis is true, that needs to be worked on as well.
Sure. One more question: does VWF or ferritin elevation precede liver injury or failure?
Yeah, so I think this is new territory. We have to now work on this more. There is a lot of work happening all over the world in this area. And as I mentioned, it is not only in liver. For example, about 10 years ago, there was a study from Texas in USA where unselected patients in pediatric ICU who had multi-organ failure and thrombocytopenia. So they called it TAMOF, thrombocytopenia associated with multi-organ failure. They could show the same phenomenon of increase of VWF and reduction in ADAMTS13 with increasing greater severity of the disease. So it's like ESR going up, but it seems to be contributing to worsening of the disease. That is the newer understanding. And in that study, they could show that by doing PLEX in patients with TAMOF, thrombocytopenia-associated multi-organ failure, there was survival benefit. In those who died, they could show at autopsy in those children that there were VWF-rich microthrombi in some of the organs which they analyzed. Now, whether it truly precedes this, I do not know the answer as yet, but I do know that with severity grades increasing cross-sectionally, these parameters increase as well.
In other words, we do address the etiology portion, correct? Treating the clinical syndrome per se as treating the underlying etiology. PLEX actually a supporting system to treat the complication or the associated pathophysiology in terms of liver involvement, reticular endothelial activation and things like that. Absolutely.
So for example, let us take an example of acute hepatitis B flare. It's an uncommon scenario which causes liver failure. Let's say the person is unconscious and LFT showing acute hepatitis, HPCG is positive, IgM core is positive. What is the current treatment? We would give an antiviral drug, let's say tenofovir or entecavir. We would give anti-cerebral edema measures, but these per se does not really improve survival. Now, in addition, we have now such patients as well. When we start doing plasma exchange with low dose steroid, it seems to be making a benefit. But our numbers are too small in that group of patients. Our largest groups are, one is rat killer, two is severe alcoholic hepatitis, which is a killer the world over, a very high mortality condition. And three is idiosyncratic DILI, which is the third commonest group. Only thing there is no single drug. It's many drugs together are often used, is where we have used it. So till we have a large enough cohort, we are not able to analyze separately, though we have already now started analyzing and sending and publishing these newer areas. But your point is very, very correct. We have to look at the etiology on each patient and address that etiology. That's why in AFLP, in pregnancy and acute fatty liver, termination of pregnancy immediately is life-saving. That's the answer there. Okay. Who knows? In some patients, maybe there may be a role for plasma exchange later on. So this is only an adjunct. It is like saying I'm intubating somebody or giving inotrope. But it's a reality that in CMC, till 3 years ago, we were not using it. And now increasingly world over, this is now starting to happen.
I think so now you should be spearheading for an RCT soon in PLEX. Is that possible? Are we anticipating that in the near future?
Yeah, there's been a lot of discussion about without doing an RCT, we cannot prove this point, as well as to have it more used by other parts of the world or other people on needs an RCT. But I'm chickening out here. So I'm saying for liver transplantation, there's no RCT. Currently, the standard of care. So once one starts seeing a benefit, then that's how liver transplant is done. So it's good. Already there are RCTs have come out now in the last 2 years, but none with low volume. What has come out now with high volume and standard volume, and they both have shown survival benefit. And increasingly the data will come out. We have been, I must say, focusing more on mechanisms of how it works. That also is good fun, and I hope it will contribute to improved patient care.
Definitely, sir. Any contraindication in terms of the hypertension from we might not start with?
Well, we have sort of kept fine-tuning our protocols, seeing the benefits that we got. So we started with 3 contraindications. One is if there is a hemodynamic instability, so then we would not do. At least that was a contraindication for us. 2 is we thought that if there is somebody had a recent GI bleed, and in our head the question was we are removing a blood clotting protein, but it cannot be one molecule. There are many such molecules. In a person with a bleed, if you start removing more VWF, which are raised levels, would the person start bleeding again? So we kept that as a relative contraindication. And thirdly, if there was sepsis. Now, we find that in patients with renal failure, with raised creatinine, they do particularly well with this treatment. So currently, for example, in use of steroids and severe alcoholic hepatitis, these 4 contraindications remain, or 3 rather, not so much hemodynamic instability, GI bleed, renal failure, and sepsis. For us, renal failure is now, in fact, they seem to do better with this therapy. Now, each patient is very sick, so it's a decision that we make on a daily. We assess the patient, is responding to treatment, is tolerating treatment, then only we go to the next session of plasma exchange. That's what we do.
Two more questions. So your experience in Plex in COVID patients?
Yeah, the theoretical basis of using this in COVID is very strong. Today's session was not geared for that, so I did not bring it along. But we have done a very well designed and executed study in CMC, where we took patients with mild, moderate, severe, and critical COVID from all medical units. Patients were involved. So there was a pan-hospital study, and we could show that as the severity of COVID increases, VW levels and ferritin increases, and again it predicts death. Only difficulty here is in liver syndromes. When we are doing, like today's patient is being done in W ward, when you do it in our ward or in HDU in the ward itself, it's easy to do. When the patient has gone into the syndrome of acute liver failure, then it's more challenging to do. So one of the challenges, the possibility of getting TRALI, transfusion-associated lung injury. Now, Vijay Alexander has just completed analysis of TRALI in our liver patients, and in patients with those who are not on any respiratory support prior to starting Plex, and I think he has more than 100 patients in his series, none developed TRALI, 0. In COVID, the starting point itself is breathlessness. Now, to figure out is it TRALI or not when we start doing Plex is a challenge. So if Plex has to be done in COVID, and as I say, the theoretical basis is quite strong, it has to be done earlier in the illness. So that does not sound to be a good strategy right now. So I feel, so have you done it? Yes, we did it. We did it for 3 patients, I think, with hepatology, with COVID. And I know under nephrology, patients who had COVID and acute kidney injury, they had better success there. But with hepatology, they did not do well. Hepatology with medicine, one was the liaison. But I feel this is the problem, that we are not getting a nice window. In W ward, this problem is not. It's a very smooth phenomenon happening. And we have a good window where we see that there's not been any TRALI at all in this patient. So that is my current stance on the use of Plex in COVID.
So the cost per se?
The cost, now it comes to around 15,000 per session of Plex. So if the person undergoes 3 sessions of Plex, is 45,000 rupees, putting in the line Excel. So I think it'll come to about ₹1,00,000. Now, when we weigh that against liver transplantation, and the patients who survive, there are amazing stories. I just had a teleconference with a patient who, I recollect her coming in and seeing me in Alpha Clinic on a Tuesday. She was planned for liver transplantation on Saturday from the city she came from. So a liver transplantation in CMC would cost 15 to 20 lakh rupees. Okay, so most patients have had such an option given in front of them. And she did, I must say, thankfully, very well with plasma exchange. And this is now about 8 months later. And it was a very nice teleconference to have. So when you weigh like that, it looks like, one, it's much cheaper compared, of course, still a costlier treatment. And two, any center which has got a blood bank, at least kidney dialysis, etc., can do this. Now, there are two types of plasma exchange. One can either use a membrane filter or a centrifugal type of plasma exchange. Theoretically, we feel we prefer centrifugal flex. Now, all over India, membrane type of dialysis machines are more available. And we've had good success with that as well. But we prefer centrifugal machine. So it's cheaper but still costly, and it's available already all over India. So it is just that, and I'm predicting in the next few years, it's likely more and more patients would be undergoing this treatment, as they already are starting to all over India with this disease. Thank you.
Right. Graph-wise, I think in another 20 years, like it's when we see this as going to be like a really standard of care for people. So I mean, at least the liver syndromes that you mentioned. So I think that's it. You are playing one of the key players in this. I mean, in the treatment modality. Thanks again, sir. I think any further questions? We'll soon be uploading a lecture in the Department of Medicine YouTube website. Thanks again, sir, for that very pictorially explained lecture. I think we really enjoyed it, and I think hopefully everyone who would have been with us through this lecture time. We'll wind up for today. Thanks again, sir.
Thank you.